first our speakers here, Dr. Jordan Feigenbaum on the left and Dr. Austin Baraki on the right. These guys are from a company called Barbell Medicine, and they are some of the most foremost subject matter experts when it comes to strength training and combining it with medicine, whether from practical application or from having the most up-to-date research and deciphering the literature. They've written publications for written articles for professional publications that we as medical providers reference, and they themselves, I think this is one of the most important things, they walk the walk, right? They're both lift, and not only do they lift, they're both competitive lifters and competed, so they hit it from both the medical side and the, hey, we're actually lifters and do this for a living side as well. Dr. Feigenbaum, on the left, he's a family practice physician, lives in San Diego, and he started the company Barbell Medicine in 2012, primarily to address this gap of, hey, how do we combine strength training with current medical practices and exercise? Dr. Baraki on the right, he's an internal medicine physician, and he actually currently works and teaches at San Antonio Military Medical Center at Fort Sam Houston in Texas. So additionally, just so you guys know, we have a little question and answer box over the last couple months or so. We've collected questions from people coming into the clinics or just coming through the hospital about concerns they have. And so after the presentation today, we'd like to field some of those questions with you guys or any additional questions you have. So with that being said, Dr. Feigenbaum, I'm going to come on up. Everyone's going to give him a round of applause.
Thank you. Thanks, man. Thank you. All right. Let's get this pulled up. How many in here have done the new ACFT already? Everybody? Oh, a lot of people. Okay, cool. Anybody nervous about it? Nobody? No, that's good. All right, cool, we're done. Okay, so what I'm gonna talk about today is low back pain. What it is, why it happens, and what we can do about it to reduce the risk of it, to manage it, really try to build some self-efficacy and your own personal knowledge base about how this applies to your life. So just to give you an example of the scope, the size of this problem. This is the leading cause of disability in almost all high-income countries, including the United States. It affects about 540 million people worldwide. The Army actually has the highest incidence of low back pain amongst all military branches. So Marines with the lowest, they're like the average, and then the Army has about double the incidence. We don't know why. I'll cut to the chase, I don't know why. That being said, from 2010 to 2014, there were about 6 million doctor's visits for low back pain for active duty military, about over 6 million, okay? Of those over 6 million doctor's visits, 91% of them were diagnosed as non-specific low back pain. So about 91% of them were diagnosed as non-specific low back pain. We'll talk about what that actually is, how that applies to you, and what we can do about it. But first we have to back up. What is pain? I know I'm not going to ask for a show of hands how many of you have had pain. I assume it's everyone. It's part of the human existence. Okay, but what is it? The way I like to describe it is that pain is an experience. It's an experience that drives behavioral changes or actions in order to protect us from something that we think is threatening, something we perceive as a threat. So anything that increases that threat, so fear, anxiety, learned experiences, people around you, increases the perception of pain. An interesting story happened while I was training at a gym about 2 years ago. There was a pull-up bar, and a woman was doing toes to bar up there, so she's bringing her toes all the way up to the bar. She fell off, so about a 10-foot drop, landed right on her back. You walk, are you all right? And then she started crying, and she started holding her back, and she refused to get up on her own after that. She had to go to the emergency room, where she was diagnosed with absolutely nothing. She went home. It doesn't mean that her experience of pain wasn't real, or that it was quote unquote all in her head. That was a real experience. She really felt the pain, but that was influenced by outside things, outside of just biological or anatomical inputs. The people descending upon her and asking her, are you okay? Oh my gosh, lay down, I'm gonna get on WebMD, what do you have? Oh my gosh, you might have fractured 3 vertebrae. That sounds bad. Or a disc sequestration. What is that? I don't know, but it's a long word, it's probably bad. Probably didn't help her. Anything that increases that threat has the potential to influence or increase pain. So if it's not understanding what something means, having fear, anxiety about it, or somebody previously close to you had the same thing and they had a bad outcome. My dad had low back pain for 30 years. He would stay on the couch, for example. It's a learned response. One of the biggest take-home points here is that pain is not attributed to just one thing. Rather, it is a combination of different things that are going on. So one, what's going on in your body from a biological or anatomical standpoint. I'm not going to tell you that what's going on inside your body has no influence on pain, okay? But that's just one aspect of it. It's just one aspect. So what's going on biologically or anatomically. Second, psychologically. What's going on with your mood, your thoughts, your feelings, your knowledge base of the experience that's happening. That can influence this perception of threat. And also socially, people around you. Okay, the environment you're in, your education level. All right, all of these things combine together to kind of generate this pain experience, or influence if you even have a pain experience in the beginning of it. To kind of make this more clear, I'd like to use this analogy to hunger. Okay, so hunger is another experience that drives behavioral change to protect us from starving. Okay, there are many different inputs. Okay, some of these you guys can probably relate to. So there are biological inputs for sure, right? Different hormones or metabolic signals can influence us to go seek food to eat, right? But how many of you have been upset or anxious and not felt like eating, or have the alternative response where you overate just because you felt sad? Maybe turn on a little Grey's Anatomy, ice cream. Just me? Okay. Alternatively, how many of you have been so busy, right, you've missed multiple meals, and then you look at your watch or you look at your phone and you say, oh gosh, I'm hungry now, because you see what time it is. Or you weren't very hungry and a bunch of people around you started eating, or you went to an event where everybody else was eating and you're like, oh, I should eat. I'm hungry now. Social inputs into your experience of hunger. So again, it's not to say that these things are all just made up or they're not real. These are real experiences. Hunger and pain are both real experiences. They're just multiple inputs that shape that experience. Okay? So in both cases, these experiences are not from a single thing. There's not a hunger generator in the brain, just one area that says, hey, be hungry now. Okay? Just like there's no pain generator, one area of the body that's saying, hey, you're in pain now. Rather, these are experiences that come from a combination of different inputs, and they're both normal experiences in life. We wouldn't want you to live a life free from pain. People who have the disorder, this congenital pain and sensitivity syndrome, they tend to die early in childhood from burns or traumas or other diseases. They just can't sense it. You wouldn't want to live a life free from pain. No more than you'd like to live a life free from hunger. You kind of want to be a little hungry. Thanksgiving just happened. Sit down, crush some food. Satisfying. To never have that feeling again? Oh man, wouldn't wish that upon anybody. So we don't want you to live this, or to expect even to have a pain-free life after you leave this talk, or Dr. Baraki's talk later on, or after the Q&A. Rather, what we'd like to do is to help the medical staff here, to help you better understand what pain is, where it comes from, so it allows you to self-manage, to be self-sufficient, so you can figure out what to do to not only manage your own pain when you have it in day-to-day life, because you're going to have it, okay, but also how to reduce the risk of having pain that interferes with your life, and also to pass the ACFT. So let's move on. Let's talk about what low back pain is specifically. I don't have to tell you guys where your low back is. You guys all know where that is. But low back pain itself is very, very common. Lifetime risk for this for adults is about 85%. So most people in here will have or have had low back pain. Okay? And again, since we're on Army base, you guys have almost double the risk of the Marines, and you have the highest risk of all military branches. Again, not sure why that is, but low back pain is very, very common. 85% of all adults will have low back pain in their life. In general, about 90% of this is called non-specific, or is diagnosed as non-specific low back pain. And this isn't really a term that's used to, this is a term just for diagnostics, okay, to like code it medically, but it's not meant to minimize the experience of the person. To say, oh, it's just non-specific and brush it off. Rather, it appropriately refers to the fact that there isn't a singular specific cause for this pain. It's not due to a herniated disc. It's not due to a torn ligament or other anatomical issue. All right? It's just nonspecific. Pain that, in this case, in the vast majority of all low back pain, is not due to any specific underlying cause, no specific pain generator. The idea that it is due to something, I got to find that one thing, that pain generator, is an oversimplification of the pain experience. We talked about this earlier. It's not just one thing, there are multiple inputs. The fancy way of talking about this oversimplification is by calling it the biomedical model of disease. It's a fancy way of saying that a symptom, low back pain in this case, has a single underlying cause. And the thought process behind that is that fixing or removing the underlying cause would fix the problem, remove the pain in this case. Well, this sounds logical in theory. It doesn't really work and can actually make the person's pain get worse, last longer, and reoccur more often. And I'll explain that. So again, most low back pain is not due to an anatomical cause in isolation. So I know you're thinking, you're like, what about herniated discs or disc problems? So herniated discs account for maybe about 2 to 5% of all low back pain. 2 to 5%. It's not a high percentage shot there. So you're like, it's my disc. It's probably not, based on statistics. Many of the common things, in fact, that are said to cause low back pain are commonly found in folks with no symptoms at all. We call them asymptomatic individuals because they have no symptoms. So for example, a bulging disc or a herniated disc is found in about 50 to 70% of individuals with no back pain symptoms aged 40 to 49. 50 to 70% of them will have at least one bulging or herniated disc on some sort of medical imaging like an MRI, and they have no symptoms. The joints that connect adjacent vertebrae, they're called facet joints. And sometimes if you get imaging like an X-ray or an MRI or a CT, they might see in there some wording that says, oh, degenerative facet joint. This occurs about 30% of asymptomatic 50-year-olds. As people get older, the percentage goes up higher and higher, okay? And these things, herniated discs, bulging discs, degenerative facet joints, all these sort of things are not reliably found in people with low back pain, which is why we use the diagnosis nonspecific low back pain. It's not specific to any one thing. Certainly not just an anatomical thing, okay? Side note, just here, using the word degenerative suggests there's something wrong or defective about the structure it refers to. So if we're talking about degenerative facet joint, oh, there's something wrong, this is bad. What's been put forth instead of using the term degenerative is to use the term age-related, which is true. If we see more and more of this degenerative facet joint finding on stuff like X-rays as people age, it's really age-related, especially if it's generally found in asymptomatic individuals and doesn't really correlate well to pain. Imagine if you went to the doctor and you had wrinkles, and they called this degenerative skin disease. Or I went to the doctor and he said, hey, what's going on up here, Feigenbaum? I guess it's degenerative hair disease. Like, what do you want me to tell you? The problem when you are talking about pain, however, is if you tell somebody that they have a degenerative disease of a joint or structure, right? You've told them, hey, this is fragile. This deserves extra attention, extra care. But also I need you to go exercise. Oh, by the way, there's this new ACFT that you're gonna have to do. And you have degenerative disc disease or degenerative facet disease. You're like, well, doc, that doesn't make sense. You just told me that I'm fragile, that these structures deserve extra attention, that I'm not whole, and now you want me to go stress these structures? To go train? That doesn't make sense. So as providers, we try to not use those terms and use either age-related or other non-medical terms where we don't build these harmful potential narratives. But you guys can use similar sort of strategies amongst yourselves. Telling somebody or thinking that you have a degenerative disc disease is not an accurate way to think about it. It's just age-related, and it's unlikely to be the source of your pain, for example, if you've been diagnosed with that. Also kind of frees you from thinking, well, I've got this degenerative disc disease, and so I can't do anything about it because it's degenerative. I'm fragile. We would prefer that you think that you're self-sufficient, you're resilient. I mean, there's all these motivational posters up here too, right? So I've talked about what pain is, what low back pain is, what it's not. We haven't really talked about the actual causes of low back pain, right? what's the magic bullet here? What are the causes for the majority of low back pain? It should be clear by now that there is no one specific cause for low back pain. Again, very common diagnosis. 85% of the world's adults are going to have low back pain sometime in their life. 90% of it is non-specific. There's no one cause for this. It's not anatomical. There's no pain generator. Rather, there are many different factors that produce this pain experience. Because there are biological, psychological, and social inputs into this pain experience for low back pain, we call this the biopsychosocial model. That's the kind of next step up from the biomedical model. And this is the current view of pain in the medical world. So from a biological standpoint, we'll go through all of these. From a biological standpoint, the workload that an individual is exposed to plays a role, such as the amount of exercise or occupational activity that they have to deal with. If you have a person who's never rucked, never lifted, never done any sort of training before at all, they come to basic training and get thrown into all of this. Now they're exercising, they're lifting weights in the gym, they're doing PT, and they're doing a bunch of extra activity. That is a new challenge for them that they have not adequately prepared for. Might they experience pain? Maybe. Effectively, they're not prepared for their orders that they've been given. Okay, so how would we reduce the risk of them developing pain from this mismatch? Well, we would have started training earlier. We would have exposed that person earlier and gradually increased the stress over time. One thing that can generate pain is having this sort of training load or workload mismatch between what somebody is prepared to do and what they are asked to do. So that can be problematic. All right. This is a huge problem in the United States also, as 80% of the United States does not actually meet the current exercise guidelines, which does involve twice weekly resistance training. Just a show of hands, you guys don't look around, so we're not using shame here. How many people actually lift weights twice a week or more? Oh, this is good, I'm so happy. Those of you who didn't raise your hand, just saying. It's okay to get in there and lift some weights. From the psychological and social standpoints, we also have a very big problem. There are learned threats from family members or close friends who've had low back pain or who have had medical providers tell them like, hey, one thing that can cause low back pain would be a herniated disc or degenerative facet joint or something else. And so the first time that you experience low back pain, that person, that close friend or family member says, oh, it's probably your disc. Like, well, I wasn't even thinking about that it was related to my disc before, but now I am. And this is a social phenomenon, particularly in the United States, where we're thinking there's something, boom, anatomical that's causing this low back pain. And it's been handed down. It's in all of the occupational safety data stuff, right? You see a person trying to lift a box off the ground one way, they're bent over, they're using their back, and that's dangerous, right? There's like pain, like cartoon pain graphics there, and they're, oh, lift with your legs. Don't stress your back. Your back is fragile. If you're on social media, you can see people pretending to lift with a rounded back and then a mushroom cloud appears over their back. These are harmful narratives, and they're pervasive. They seep into our subconscious as a society where we think, our backs are very fragile, we can damage them very easily, we need to be careful. We only get one spine. So, with all this in mind, what should we do? Well, the first thing is good news. Even though low back pain is super common, right? 85% of adults are going to have it. And most of these cases resolve on their own in about 4 to 6 weeks. 4 to 6 weeks. Most of them resolve on their own. I understand that the experience, particularly the first few days of having low back pain, you think, this is the worst thing I've ever experienced. It's never going to end. Okay, I've been there. However, that sort of catastrophic thinking actually makes it worse. If you know now, you've been inculcated, that it's going to end in 4 to 6 weeks on average, you're already set up for more success than you were before walking into this presentation. Here's the other thing. I know what you're saying. I know what you're thinking. You're like, all right, I get it. You're saying pain's all this touchy-feely emotional stuff. But what if it is a disc issue? What if I legitimately herniated a disc? I was doing the new ACFT, the trap bar deadlift test, and I herniated a disc, it shot across the room. What now, doctor? Well, the good news is, even if it was a disc issue, which again is only responsible for about 2 to 5% of low back pain, most disc issues tend to resolve spontaneously on their own, meaning the herniation regresses on its own. The worse the herniation is, the higher percentage chance that it's going to resolve on its own. So it's called disc sequestration. It's a part of the fragment that's actually been ejected from the disc. It's floating around on its own. Has a 96% chance of spontaneously regressing on its own without you doing anything other than like living. Good news, right? So let's talk about some other things that people commonly ask for because they think it's going to make them better. People say, doc, look, got this pain, I need an x-ray. Need to make sure it's not something serious. Well, the first thing is imaging doesn't show pain. It only shows bony things if we're talking about x-rays, or additional non-bony things if we're talking about advanced imaging like MRIs and CTs. Okay, so it doesn't show pain. The current recommendation is to not actually get an x-ray until after 6 weeks, unless there's a suspicion of something more serious like a cancer or an infection. Okay, a handful of other things that the doctor will be able to pick up on exam, which makes sense. So that 6-week mark, again, most people's low back pain should have resolved 4 to 6 weeks. All right, so after that, then you might be thinking, if you're the medical provider, hey, maybe I missed something. Okay, x-ray at that point might be something to do. The reason why we don't do it in the first 6 weeks, one, it doesn't change what we do. Getting an x-ray doesn't say, ooh, you need to do exactly this. Okay, doesn't show pain. And you might find something that's incidental, that's completely normal, just a normal variation of anatomy, but subjects a person to a more extensive workup, like getting an MRI or getting a CT. Those who get an MRI for low back pain tend to do the same as those who don't, or even worse in some cases. There's more incidence of disability. Also, an MRI doesn't actually do a great job at finding issues. When you have different radiologists looking at the same images, they'll find different things and not tend to disagree with each other about what they actually find, because we're humans and we do that. So my favorite study, and I was really trying to not quote any single study in this particular lecture, but this is my favorite study. They sent this little old lady to 10 different radiologists or MRI centers. Each had their own different radiologist, right? And so it's the same spine, they're taking a picture of the same spine, and these radiologists with all similar levels of training are interpreting this, and they didn't agree on any one single finding. There were over 50 different findings that they reported across these 10 different MRI centers. Not one single one was repeated across all 10, okay? And they found a ton of false positives, meaning they identified stuff that wasn't there. I know what we're thinking, that MRI is this gold standard, we need it, it's going to help us, but in the case of low back pain, probably not. The common thread is that the military doesn't want to spend the money. They're tightwads. It just really doesn't help in this case. And my experience with military medicine, I did 2 rotations at Navy Portsmouth Hospital, a psych rotation and an emergency medicine rotation. They tend to spend more money on medicine. They're like, it's the military, they'll pay for this, order all the tests. The thing is, it just doesn't really help, and it may in fact hurt you here, right? So think about it. If you have low back pain as an adult, it just started a week ago, you finally go to see the doctor because you're worried, which is fine, this is normal, okay? And they say, you know what, let's get an MRI. You get an MRI and it shows 3 herniated discs, which you didn't know that you had before, okay? If you hadn't come to this presentation, you might be thinking, boom, there it is. Not the song, which is whoomp, there it is. This was boom, there it is. 3 herniated discs, that's what's causing my pain. I will be in pain until these discs reabsorb, or until I have surgery, or until these discs spontaneously regress, which is not the case. Again, many asymptomatic individuals, 50 to 70% of those ages 40 to 49, will have herniated disc on MRI and be asymptomatic. I know this because during my medical residency, I got an MRI and it showed 3 herniated discs, And I didn't even have back pain. That's not why I got the MRI. Anyway, yeah, that was a traumatic experience. I still try to not think about it anymore. So advanced imaging, we probably wouldn't recommend. We probably wouldn't push for it. Hopefully you guys are on board with that. Next thing people say, all right, well, what about meds, doc? No imaging? You work for Big Pharma. What meds should I take? Unfortunately, we don't have a lot of good solutions here from a medication standpoint. So over-the-counter medications like Tylenol and ibuprofen have either no evidence that they help in low back pain. For Tylenol, does not help, would not recommend, or very little benefit, ibuprofen, would not recommend. And that's, again, people, it kind of makes sense because back pain, particularly the majority of this back pain that people experience, is not inflammatory. So people say, yeah, but I take ibuprofen when I have low back pain or a little back tweak and it makes me feel better. Why? It's like, well, it's hard to separate out the placebo effect from what's really happening. You're taking a medication, there's a ritual there, there's an expectation that you're gonna get better, and so you feel a little better, sometimes, okay? That being said, when it's actually widely studied, not a lot of good evidence there. Same thing, prescription medications like steroids, like, doc, I want an injection, or I wanna take prednisone, I took that once, made me feel great. No really good evidence that these actually have any benefit here. Opioids, very little benefit in chronic low back pain, so lasting more than 6 weeks, but harmful in the long term. You guys have been keeping up with the news, you know that to be the case. So this should all make sense to you that just taking a medication probably doesn't do a great job at addressing low back pain due to the multifactorial nature of the pain experience. If it was just a biological cause, then sure, maybe medications would be more efficacious, they'd work better. But because there are biological, psychological, social, environmental inputs all to this sort of pain experience, it makes sense that medication's not a magic bullet, okay? Similarly, if we're looking for this one cause of pain, the pain generator, we're gonna be on a wild goose hunt, and we may misattribute the pain experience to a TWD, which is time wasted on useless detail. We might look at imaging and say, oh, I have facet joint degeneration, that's what's causing this, and until I get that fixed, I'll never be whole. I'll never not have low back pain. Could hold you back in the long term, okay? So since there are biological and psychosocial inputs that drive this pain experience, those are the targets we should actually address. So let's talk about those. Biological, let's talk about exercise. So I started this earlier on saying that one of the reasons why one of the biological causes where people can have this most common type of low back pain is when the training stress or workload outstrips what somebody is prepared for. It increases too quickly and too much. So preparing for the demands via training that gradually increases over time is how we would address this. So we would start people with something that they can tolerate today, right now, okay, and then gradually increase that stress over time. I know this is just shocking. But this is also how we would start treating this type of low back pain. So let's say somebody tried the new trap bar deadlift test, right? And they said that they had back pain after that. That's a traumatic experience. They know they have to do this test to keep their job, okay? And they did it once, and then they had back pain afterwards. They're like, see, look, I did the deadlift, and then now my back hurts. And now you're telling me I have to do it again anyway? So what would we do in that situation? Well, one biological cause for somebody to have back pain after that is if they've never deadlifted before, and now you put them into a competitive or testing situation, it's probably not the best way to do it. What we would rather have them do is be exposed to it under a less challenging situation and gradually work them up to the test they're gonna have to do. That's training over a longer period of time. That might mean starting with just the empty bar, okay? In this case, after somebody already has pain, what we wanna do is desensitize them. We wanna reduce the threat. So they even see the trap bar, they no, I can't. They have PTSD. What I'd love to get them to do is do a trap bar deadlift from a reduced range of motion, maybe from a higher platform, right? Or if they were previously doing it with weight on the bar, do it with just the empty bar. Something where they could do the movement as close as possible to the movement that they're gonna be asked to do, but that they're able to tolerate. We're gonna try to desensitize them, reduce the threat, reduce the fear. around that. Now, if they won't do it at all, we'll do something else that's similar. will gradually have to move farther and farther away, okay, from what they need to prepare for. But what we'd like to do ideally is if somebody said, look, I hurt my back doing the trap bar deadlift, what do you recommend I do? I think you should do the trap bar deadlift again, but at a more manageable load, whether that's total weight, total reps, sets, etc. The whole training load needs to be appropriate for what you can handle right now, and that has to be gradually built up over time. All right, getting stronger over time is going to help the individual or you to be more tolerant of different stresses, particularly those around physical activity. It also helps build self-efficacy. So if someone comes into me and says, hey, I have back pain, I did it while I was doing the trap bar deadlift for the new Army Physical Fitness test, what do you recommend that I do? I'd say, look, I think, I'd ask them, what was your previous exercise history? And get that information, and I'd say, I think you need to do the trap bar deadlift in addition to these other exercises to get you fit for duty. And here's how I would do that. And you need to be in charge of this. Get the process of going through this sort of training-based rehabilitation builds self-efficacy. You're the one who's responsible to get better. You don't need to come see me multiple times a week for an adjustment, for a massage, for a pep talk. Rather, I want to give you the power to manage this on your own. All right. The last part of this with respect to exercise is a term we call autoregulation, which is a fancy way of saying adjusting things based on the amount of resources that you have. So imagine a situation where you're sleep deprived, or you're really sad, or really upset, or you're really hungry, or something that ultimately puts you not at your best. Relationship stress, occupational stress, something like that, okay? And it's really bad. And you're not able to perform up to your best. You're not able to tolerate as much training stress as you would when everything's going your way. So our recommendation would be, instead of just pushing through it because pain don't hurt and pain is weakness leaving the body, is to have some sort of stopgap in place where you don't end up pushing too far too quickly. So easy ways to do this. Most of your training sessions that you're doing in the gym, because all of you are now going to be engaging in resistance training, most of your training sessions, if you were going to rate how hard they were, how fatigued you were at the end of the training session, should be about 6 to 8 on a scale of 1 to 10. If at the end of every training session you're like, that was a 10, I've never been more tired than this after exercise, this is it, that's probably too much for you. It's probably too much. On the other hand, if it's a 2, you're like, I'm fine. It's probably not enough to encourage change, okay? 6 to 8 is kind of that sweet spot. And so during periods of high stress, right, for whatever reason, keeping it in that ballpark is going to kind of keep you safe from a training perspective. You're not going to be able to, ideally, push yourself into that, hey, I did too much for what I was prepared for, okay? So that's from an exercise standpoint, what should we do? From a psychosocial standpoint, the first thing we can do, and what we're trying to do right now, is education about what pain is, why people have pain. There's no pain generator, we talked about that. Pain doesn't necessarily equal harm, okay, like harm to the tissue or tissue damage. If you know anybody who's been to war and maybe still has shrapnel in their body, that's the definition of tissue damage, and they may or may not have pain from that, for example, okay? And during this educational period, we'd also like to give you tools so that you can self-manage, whether that's exercise advice, whether that's managing your training, whether that's new information about just straight up what doesn't cause pain. All of these things can be helpful. So that can be super useful. And then finally, from a social standpoint, I'd really like to encourage all of us, everybody in this room, to watch our words and actions, of what we say to each other and how we act towards each other with respect to pain. So if you happen to see a woman or a man fall off a pull-up structure onto the ground, get up and walk away just fine, just go on living your life. You don't need to go over and ask them if they have back pain now and tell them to sit down and then go on WebMD. They're probably going to be fine. All right. If you have low back pain, we would highly encourage you to stay calm, to not catastrophize it and saying, oh, this is probably something traumatic, because it's probably not. Okay, and then to try to talk yourself into self-managing. If you need a professional counsel, we'd like you to see a healthcare provider who's trained up on this stuff. And then when we're talking to friends about what causes pain, when somebody says, yeah, I have a bad disc, that's what's causing the pain. If you feel comfortable talking to them about this stuff, you might try to engage in a conversation where you can provide them more information. If it's your Uber driver, maybe just say, oh yeah, that's wild, and then don't say anything else. It's a long drive from here to Barstow, as I found out yesterday. All right, so let's wrap this up with some take-home messages. Take-homes here. Pain is an experience that we have in order to try to protect ourselves from a perceived threat. The threat is a combination of many different factors. It's not just one thing. Anything that increases that threat is going to increase, has the likelihood of increasing our pain. So whether that's fear, whether that's not knowing like what's going on, all right, or a learned experience, all of those things can increase pain. Most low back pain is not due to something serious like a fracture, mass, or infection. Most of it resolves in 4 to 6 weeks on its own. We covered, I think, in some pretty good detail that it's most likely not related to some anatomical issue like a disc, facet joint, or anything like that. To treat and reduce the risk of low back pain, we need to exercise and build tolerance and reduce sensitivity. Motion is lotion. All right? So if you're having low back pain, the worst thing you can do is be sedentary, not exercise. The best thing you could do is try to do exercise an exercise that's very similar to what you were doing when you got hurt, all right? Potentially with a reduced load, potentially with a reduced range of motion, potentially with an altered tempo. The idea is, again, not to be scared of it and to desensitize you to that exercise, to that motion. It's all about violation expectation in that instance, meaning that you expect yourself to have pain when you bend over, for example, if you hurt yourself deadlifting. Well, we'd like to prove to you that that's not always going to be the case. And if we can violate that expectation, we can put you on this path towards improving self-efficacy and you being able to self-manage this on your own. And then finally, ideally, you would all be part of a social change revolution to change the way that we all think and talk about back pain in society. Because we can't do this on our own. There's only 2 of us. But as we get to kind of spread this message to folks, the idea is that this becomes less and less of a problem. I thank you for your time. We'll do a Q&A now.
See the sky, see the clouds amongst the sun. See the day for everything it could be. Stop treading on that snooze button, run. Open your eyes and see everything it was, and is and will be all at once. See the truth.